Hi, everyone. My name is Jeff Unger. I'm a family physician and a diabetologist located in Southern California. And I've noticed something over the last couple of years. A lot of my patients have poorly controlled diabetes, and I'm a diabetologist. I should be able to fix these things, but they're failing. And my job is to figure out why. I don't blame the patients. What I do, however, is I've been screening for hypercortisolism. And amazingly, about 25 to 50% of my patients have excess cortisol. Therefore, the purpose of this discussion today is to give you some information on how hypercortisolism can really screw people up and how you could be heroes in your own practice. So, we want to be able to identify patients suspected of having hypercortisolism. I'm going to take a look at the diagnostic challenges associated with hypercortisolism. And interestingly, this is something we've learned about over the last 70 years, that there's something called hypercortisolism out there. However, it's only in the textbooks, it's not in clinical practice. That's why we have to step up to the plate to make this diagnosis and help our patients. And I'm also going to explain why hypercortisolism can have an adverse effect on blood glucose levels. It's not that the patient is non-compliant. It's because we are missing hypercortisolism in clinical practice. So, what are we talking about here? Cortisol is a stress hormone. It's produced in the body to get people ready for the physical and emotional stressors of the day. And cortisol production is based on several factors. There could be cortisol coming from the adrenal glands in excess in a process called adrenal hyperplasia. There could be something called a functional adenoma, which could be increasing cortisol production. But also, if the pituitary gland is overproducing ACTH, adrenocorticotropin hormone, the ACTH goes to the adrenal gland and causes the adrenal gland to put out extra cortisol. Chronic exposure to hypercortisolism really screws up the body. And it's very interesting that these are people that we see in clinical practice every day. It can affect sleep, it can affect bones, it can affect the kidneys, it can affect the liver. It certainly affects eyes. It causes dry eyes as well. It results in fractures, even in men. In fact, I recently had a man that's 45 years old that came in multiple fractures. The most recent one was a person stepping on his foot in a pool, broke his foot. Could he have hypercortisolism? You bet. He does. Now, we've learned a lot about hypercortisolism in the last year. There was a study that was produced called the Catalyst study, which showed that people that are using more than two diabetes meds, two or more, plus insulin, plus two or more antihypertensive meds, have a 1 in 4 chance of suffering from hypercortisolism, also known as Cushing's. I should point out that Cushing's has a couple of different connotations. Cushing's disease means that the problem is coming from the pituitary gland, overproduction of ACTH. Cushing's syndrome means that the problem is coming from adrenal hyperplasia. So this is Riley, very interesting lady. She was actually referred to me by a psychiatrist, and the psychiatrist couldn't help her and was thinking maybe there's something going on on the endocrine system. She's had depression chronically for 11 years, has failed multiple treatments for depression, but she's also an athlete and she played collegiate rugby. She was in good shape. And then over the last 6 years, she's gained 65 pounds. She's tired. She also has a lot of other problems, including hair loss, easy bruising. She's had dysfunctional bleeding, acne, really, really bad mood swings all day long, and loss of sexual desire. But look at this. Her A1C is 7.8. She's taking metformin, semaglutide, and empagliflozin. Tell me this. How often do you see people gain 60 pounds while taking semaglutide? Not often. Her physical exam shows that she's got hypertension, she's overweight, she's got rosacea in her cheeks, She's got facial hair, big abdominal striae, and when you take her arm and you have her push against resistance, this rugby player can't push you through the wall. Look at this face. I'm going to show you a follow-up coming up. But this is how these people with hypercortisolism looks. So we downloaded her CGM, and remember, she's on multiple meds. Her blood pressure isn't controlled, her weight's not controlled, and certainly her blood sugar is terrible. On her time and range, it's only 55%, and she's got a lot of variability up and down all over the place. Her A1C is 7.8, and her GMI, glucose management indicator, is also high at 7.7. So this patient comes in, she's very depressed, she's miserable, nothing's working, and what are you going to do? Say, hey, Riley, it's your fault. You're non-compliant. No, we got to look for hypercortisolism. So hypercortisolism, as I mentioned, can really screw up every part of the body. It makes you gain weight. Why? Cortisol binds first and foremost to the brain. And when it does that, the satiety is reduced. So people tend to gain weight. It also makes you very depressed. Remember, I'm going to repeat it again. Cortisol binds to the brain and makes you depressed. It can increase the risk of cardiovascular disease. In fact, one of the reasons we have to identify and treat these patients is because if we don't, there's a 5 to 6 fold increased risk of cardiovascular disease, including atrial fibrillation in young people and including congestive heart failure. Also, high cortisol can cause calcium to be lost from the bone, and that means the patient's going to be at risk for fracture. It causes something called proteolysis. And what proteolysis means is if you can't put glucose in muscle cells, those muscle cells become weak. And these people have chronic pain. They hurt all over the place. They have a hard time getting out of a chair. They have menstrual irregularities. They have deep venous thromboses, and they certainly have significant diabetes or insulin resistance. So here's a question I always ask my patient. It's a good slide to remember. I ask, all right, how does glucose get into cells in the first place? Remember, glucose is the only source of energy for cells. We can't hook the cell up to an electrical source to power it. We've got to get glucose from the cell. So how does it work? Well, insulin binds to a cell. When insulin binds to the cell produces something called GLUT4, GLUT4. All this GLUT4 is a stupid day worker. It's a glucose transporter, and GLUT4 goes to the cell surface. It grabs the glucose and it brings it into the cell. Aha! At that point in time, the cell is working. But whoa, wait a second. There's also something called a glucocorticoid receptor, also known as a GR receptor on the cell surface. If cortisol levels are high in hypercortisolism, it blunts the effect of GLUT4. Well, what happens then? Well, glucose can't get in the cell, it stays in the blood, and your blood sugar goes up. And if glucose can't get into the cell, it can't trigger muscles to contract. You can have weakness and you're going to have pain. All these symptoms and signs in this slide are something we see in primary care. You ever see people with dry eyes, depression? They're tired, they can't sleep, they're gaining weight. They have, even though they feel that they're not eating very well, they have a hard time thinking. They have loss of sexual desire. They're moody, they're irritable, they have irregular periods. And I'm bringing this up because since when does an endocrinologist fix depression? On their physical signs, they have and I'll show you these. They have a big fat pad on the back of their neck. They have supraclavicular fullness. Their face is really red and hot and swollen. They have acne. They have sores all over the legs. Their skin is dry as well. And oh yeah, what about this? They have hypertension. They have vertebral fractures. They have kidney stones. They can have low potassium. And they've got type 2 diabetes. See, these are the people that they have wounds in their legs and they don't heal. So what are you going to do? You're going to send these people to a wound doctor? No. You're going to screen these people for hypercortisolism. So these are some of the things we see, and you can look all over and find these people, not in your office, but you could just look at a mall. You can look at the patient on the top left there. The way you look at facial plethora, look at them straight on. If their face is big and you cannot see their ears, they have something called chipmunk faces. And these are the people that pretty much have hypercortisolism as well. They can be overweight, obviously, but look at those striae, the bottom right. When I see this, I get really excited because this means that this is not due to pregnancy. This is due to hypercortisolism. And then you can look at the neck and feel around the supraclavicular areas. This is fat. How do the people get this? This is long-acting effect of hypercortisolism. The problem here is that not all people look like this. There are some people that look really skinny, that look normal, but they have kidney stones. They can have atrial fibrillation. They can have an MI in their 30s or 40s, and you start thinking, what am I missing here? Could this be hypercortisolism? So let's take a look at how cortisol works. Cortisol, as I mentioned, is a stress hormone. It's necessary for life. No cortisol, you die. No cortisol, you have Addison's disease. So cortisol is produced typically overnight. It starts peaking around 3 a.m. so that by the time the patient wakes up at 8 a.m., they're ready to go with the physical and emotional stressors of the day. This is a normal graph. Look what happens at 10 o'clock at night. That's arrow number 2. Cortisol levels are typically very, very low. However, if you have hypercortisolism, look what happens. Cortisol levels are up throughout the day. And when you try to go to sleep at 10 o'clock at night, cortisol levels are sky high. You can't sleep. And look what happens overnight. Cortisol levels are really high. And what does that mean? People can't sleep. If you can't sleep, you can't think. You start losing your memory. You become moody and irritable. You fall asleep during the day just from exhaustion. So, how do we screen for Cushing's disease? How do you know that people have it? Well, there's 3 ways to do it. You could do a late night salivary cortisol because you're looking at cortisol levels at night just before bedtime. You should be really low at that point in time. If they're high, that's an indication that they have hypercortisolism. But the screening method of choice is dexamethasone. So dexamethasone is a very potent steroid. It is taken at 11 o'clock at night, the night before you're going to do an AM cortisol. Now, it's so potent, this dexamethasone, when I give it to somebody at 11 o'clock at night, it's going to knock down their cortisol level, their endogenous cortisol level, to close to zero the next day. That's normal. But if you do a morning cortisol level at 8 a.m., they have to be in the lab. It's a timed test. If the cortisol level is above 1.8, that means there is no suppression despite using dexamethasone. And in this case, the patient is diagnosed as having hypercortisolism. So there's 2 tests you got to do. First, you got to get the dex level done. A dex level above 140 is suggestive that the patient actually took the drug. Like Ronald Reagan said, we've got to trust but verify. Above 140, they took the drug. And if their AM cortisol is above 1.8, then that means they've got Cushing's. You also have to get an ACTH level done as well. And the way to remember this is if you're looking at where is this extra source of cortisol coming from. If the ACTH is high, I'm reaching above my head, it's coming from the brain. If the DHEAS is low, it's coming from the adrenal glands. So how do we treat this once you identify the type of patient you're dealing with here? There are several different options. One of the drugs called mifepristone blocks cortisol receptors. And there's 2 other drugs you can see here that don't block receptors, but they reduce the amount of cortisol the patient is making. I'm not going to get into these drugs in particular. All I'm doing is putting this up to show you the treatment is there. Also, we've got to recognize that if somebody has a adrenal adenoma or a pituitary adenoma, then the best treatment may be surgical. Unfortunately, if somebody has an adrenal adenoma and they're young women, there's a really good chance, a 40% chance of tumor reoccurrence. Remember Riley? I showed you this patient when we started. She was diagnosed as having a pituitary adenoma. Look on the left, that's before. Then we diagnosed her and we took out the pituitary adenoma. This is after. What a big difference. Unfortunately, after a couple of years, Riley's pituitary adenoma reoccurred. So we needed to treat her medically. And I just want to show you what these people actually look like when they have normal cortisol levels. Here's our key takeaways. Hypercortisolism can cause insulin resistance and poorly controlled hypertension. Patients with hypercortisolism present not to the endocrinologist, but to primary care with complaints including fatigue, anxiety, depression, weight gain, even on GLP-1s. They are anxious. They're always looking around, saying, "What's going on?" They're nervous. They're tired. They have dry eyes. They're weak. They're nauseated. They have myalgias everywhere in the body. Hurts. They're weak. They can get deep venous thrombosis, wound infections, poorly controlled diabetes and hypertension. Doesn't this sound like the typical patient we see every day, all the time in our practice? If you think the patient may have hypercortisolism, you screen with a 1 milligram dexamethasone test. If the dex level is above 140 and the AM cortisol level is above 1.8, they've got biochemical evidence of hypercortisolism. Then you got to figure out where this is coming from. 60% of the time, you never find out, but you still treat because if you don't, these people have a much higher risk of mortality. And this is another one of our patients that we have with hypercortisolism. This is the before and after. This patient is a special ed teacher. She's 44 years old. She was diagnosed as having disability. That was it. Because she was so tired, she couldn't do her special ed class. But she had bilateral adrenal hyperplasia. We treated her medically. Look at the difference after 2 years. So, thank you very much for your attention. I hope this was useful for you. And go out there and find these people. I appreciate you. Thank you.